And when we talk about the renin-angiotensin-aldosterone system, we're really talking about fluid volume and blood pressure. Those are the things that we're concerned with. So anytime we're looking at this system, we're looking at fluid volume and what effect that's going to have on blood pressure. It is important to note that sodium balance can also be controlled by this RAA system. So first I wanted to differentiate between renin and renin. Renin is what we're talking about here in the Renin-Angiotensin-Aldosterone Axis or system. And renin is actually a GI hormone. And axis versus system, really it's the same thing, so you may hear both terms used. In some examples of issues that may cause the RAA system to be activated or utilized would be hemorrhage, dehydration, sodium deficiency, decreased renal perfusion, really anything that is going to make the kidneys think that we don't have enough fluid, we don't have high enough blood pressure, something that's going to alarm the kidneys. This is the diagram that I've created that I'm going to use to kind of explain the renin-angiotensin-aldosterone system or axis. And before I really get into explaining the diagram, I want to review a little bit about how the kidneys work. So the kidneys, and really it's the juxtaglomerular apparatus, they're very sensitive to changes in blood pressure, and they can sense if there is decreased perfusion or blood flow or decreased blood pressure, if you want to think of it that way, to the kidneys. And they respond by activating that RAA axis. So the RAA axis is meant to increase blood pressure or increase fluid volume or increase sodium or any combination of those. So not only does the end product of the RAA axis, which is aldosterone, increase fluid retention and also increase blood pressure, but angiotensin II, which is also one of the products that we make, has some other systemic effects, and we'll go through all these as we run through the system. So first of all, if you look at the top left of this diagram, when we start at the kidneys in step 1, so the juxtaglomerular apparatus senses decreased renal perfusion. So we have dehydration, or maybe the person has heart failure and the heart muscle, it's a systolic failure, the heart muscle isn't pumping very well. So the kidneys say, man, we need more fluid. We don't have enough fluid and our blood pressure is low. And so what the kidneys will do is they release renin, and that's that hormone renin. Renin then ends up being broken down at step 3 by angiotensinogen into angiotensin 1. And the liver was producing that angiotensinogen, which was step 2. So we have the renin breaking down into being broken down by angiotensinogen into angiotensin 1. Okay, so angiotensin 1 then goes to the lungs, and that's at step 4. They're kind of at the bottom right-ish part of your diagram. Angiotensin 1 is converted by angiotensin converting enzyme, which we also call ACE, and we'll talk about ACE inhibitors. It's a blood pressure medication. So it converted by ACE into angiotensin 2. So the lungs is where we have this conversion occur. So angiotensin 1 converted by ACE into angiotensin 2. Now angiotensin 2, like I kind of briefly mentioned, it has its own effects, and that can be stimulating the posterior pituitary to increase ADH or antidiuretic hormone secretion. So that's going to cause water retention because the antidiuretic hormone is going to say, hey, don't diurese, don't let more fluid go out of the body. That will, of course, then increase fluid volume, increase blood pressure. Also, it can stimulate the sympathetic nervous system, so the fight or flight response. It can cause the kidneys to increase tubular excretion of potassium, so we get rid of more potassium. And there can be some vasoconstriction effects. Then also, angiotensin 2 then goes to the adrenal cortex back in the kidney, so that's kind of on the left side of our diagram here. And at number 5, angiotensin 2 causes the adrenal cortex to produce aldosterone. So here we get aldosterone. And aldosterone itself is going to increase sodium and chloride retention. And remember, water follows salt, water follows sodium. And so we're going to increase our fluid volume. And when we increase fluid volume, we also increase our blood pressure. Furthermore, the aldosterone will cause an increase in potassium excretion in the renal tubules. So we have really the renin at the very top of the system, starting at the beginning. Then that becomes angiotensin 1, which then becomes angiotensin 2. Angiotensin 2 has its own effects, plus then it goes on to cause the adrenal cortex to release aldosterone, and the aldosterone has its effects. And so you're questioning maybe, well, why do I need to understand, especially as a nurse, why do I need to understand each of these hormones and this whole process itself? And I'm going to explain that here. So a lot of your diseases can be exacerbated or worsened by the RAA system. So on one hand, while we may benefit from this system if we're dehydrated and our body is going to automatically help us keep more fluid around, it can actually worsen a disease like heart failure. So if you think of especially left-sided heart failure or systolic heart failure, where the heart is not able to pump effectively blood out to the body, and we get a buildup of fluid, especially in the lungs. And then that fluid can continue to build up. We can get edema, especially if we have then right-sided failure. And we may have peripheral edema. You might have pitting edema around the ankles and so forth. May even have ascites. Well, if you think about one of the number one medications we give for heart failure, it's a diuretic, so maybe a furosemide or Lasix, and we might even give spironolactone, aldactone, or hydrochlorothiazide even. So any of these diuretics, what are they doing? They're getting rid of extra fluid. But what does the RAA system do? It makes more fluid stay around in our body. So, what happens in heart failure is the kidneys think our blood pressure is decreased, and we don't have as good a perfusion to the kidneys because of this heart failure, because that heart muscle is not pumping great, it's too weak. So the kidneys kick in the RAA system and we make too much fluid. So this counteracts what we really need to happen. It's kind of like the kidney is doing its own thing. It has a mind of its own, and even though we truly don't need extra fluid, the kidneys think we do in heart failure. And so, like I mentioned, we give diuretics to kind of help, hopefully, get rid of the extra fluid that's potentially made by the RAA system, and then also the fluid that accumulates just because of the ineffective pumping action of the heart. But it's not just diuretics that help us to get rid of extra fluid. You also think about ACE inhibitors. ACE, again, is the angiotensin converting enzyme, and if you look at the diagram there, kind of on the right side at the lungs, it's step 4, where angiotensin 1 is converted by ACE, or angiotensin converting enzyme, into angiotensin 2. Well, if you have an ACE inhibitor, you can also think of it as an ACE blocker. If you take that medication, it's going to make it so that angiotensin 1 cannot become angiotensin 2. So sure, the kidneys can release renin, and that renin can be turned into angiotensin 1. But if you take an ACE inhibitor, in the lungs, that conversion from angiotensin 1 to angiotensin 2 can't happen. And so we kind of break that cycle, this whole system, so that it cannot occur. So we can't then produce angiotensin 2 and can't make aldosterone, or at least can't make as much of it. And that's going to help us decrease that increase in fluid. And so hopefully we'll be able to prevent too much fluid and help a person with heart failure, for instance, live a hopefully less complicated life. They won't have as many exacerbations of their heart failure and so forth because they're able to control their fluid volume. And then also you have ARBs, which are similar to ACE inhibitors, but ARBs are angiotensin receptor 2 blockers. So they just block in a little bit different place. And if you think about ACE inhibitors especially, I want to go back to them for just a second. One of the most common side effects that will frequently cause people to stop taking them is a cough, a dry cough. And it makes sense when you think about that this conversion happens in the lungs, and so one of the most common side effects is a cough, which also would occur in the lungs. That's just a way you can remember that. So I want to do a little bit of review. So renin is the first step, and it's the renal hormone that breaks down into angiotensin 1. And so again, it's just that very first part. After that, renin is converted into angiotensin 1. Angiotensin 1 is then converted in the lungs into angiotensin 2, and that's where that ACE comes in. So then you have angiotensin 2. Angiotensin 2 will increase ADH secretion, so we keep more water around, stimulate the sympathetic nervous system, which is fight or flight, will cause secretion of potassium, also cause some vasoconstriction, and then it stimulates the aldosterone secretion. And aldosterone, remember, is going to then increase sodium and increase chloride retention. Both of those things can lead to increased water retention, and then we also will have more potassium excretion. And so all of these things, again, that deal with our AA axis or system, all of these things are going to increase sodium, usually decrease potassium a little. They in general will increase vasoconstriction, and all of those things will combine to help to increase blood pressure, whether we want that or not. And I make that point again, that with this system, it can be very helpful to us, but it can also exacerbate or worsen a lot of conditions because it does increase blood pressure or keep more fluid around sometimes when we don't necessarily want that. So keep that in mind. And also keep in mind that when we talk about the RAA system, it's all about the application of that. So why is it important? And it's important because it helps us to understand medications like diuretics and ACE inhibitors and ARBs. So when you're trying to make sense of these medications, also always ask when you give a patient this medication, why am I giving this medication? Okay, if I'm giving a diuretic, it makes sense to me. I'm giving this diuretic because we need to get rid of the extra fluid. Same thing with the ACE, and in this case with ACE, you're preventing that conversion from angiotensin 1 to angiotensin 2 in the lungs, or similar with the ARB. So this is a very important system, and it really will help you, if you understand it, it will help you to understand the pathophysiologies and maybe the complications of this system within those pathophysiologies.